So variations on the theme. Let's talk about this guy, 67-year-old male. He also has HCC, but this time he has portal hypertension. As you can see by a big spleen there, 10-centimeter tumor. Sit at your tumor board. What are you guys looking at?
With portal hypertension, it looks like he's going to need at least a right. I'm assuming not an extended right hepatectomy. And I don't think our surgeons are going to do an operation. Correct me if I'm wrong. Would you do a surgery here?
I would not.
You did not. Don't worry on this one.
And so without macrovascular invasion, this patient's going to get locoregional therapy. The question becomes, are they going to be ever considered for a liver transplant, with downstaging? And that's always a huge gray zone as to, what is the official downstaging criteria. I would argue there's nothing official anymore. It's, it's kind of individualized at this point. But we would start with locoregional therapy in this case, and given the size of the tumor, it would be a radioembolization.
And I don't know if I mentioned for the listeners, this is a 10-centimeter tumor that's occupying essentially the entirety of the right lobe of the liver. Dr. Burgoyne, would you offer systemic therapy over locoregional therapy for this patient?
Not outside of a clinical trial. I mean, if it's a targetable lesion by Y90, and that is going to have a higher response rate than immunotherapy and a higher likelihood of downstaging this patient if that's our goal.
Are there any current clinical trials in the U.S. for BCLC? This would be actually A. So this is actually technically BCLC-A. Are there any ongoing trials in BCLC-A right now? It may not be offered at UCSD or UCLA. I'm just curious.
There are, and Zach can comment on this too, but the studies that are asking this question of TARE plus immunotherapy typically don't stratify by BCLC-C, more as what is the amount of tumor in the liver and is it targetable Y90? So a patient like this would potentially be eligible for one of those studies for combination. Exactly.
So we took Sid's advice and took them for a mapping procedure, and their lung shunt was 37%. Could not get an effective, or at least what I would consider an effective dose of radioembolization.
Okay.
What would you do now?
So if they can't get an effective dose, there's a couple of things that you can do. You'd have to look at your angiogram to see if there was some shunting that you could shut down. And that obviously takes a lot of study to look at your angiogram and so on. The other option is to switch, right? So in our practice, if let's say we can't figure out a way around it, we switch therapies. You go to plan B. And in this case, that's chemoembolization. We kind of forget about chemoembolization because our practice tends to be so Y90 heavy, similar to yours. But keep in mind, chemoembolization has been the mainstay of BCLC A and B for the last 25 years, or close to 25 years. And so this patient would most likely get a chemoembolization without me looking at the mapping angiogram. And then we can always do the TACE, restage, and then put all options on the table again. It doesn't have to be, once you're doing TACE, you still have to do it. You can always switch back. You're not really, set into one specific treatment algorithm. You can switch to systemic, et cetera.
Yeah, so we did a round of TACE and then redid the mapping procedure, and we got their lung shunt down to about 20-25%. Still, not quite happy with the amount of dose given how large the tumor was and the size of the territory. How do you feel about systemic therapy in this setting?
Well, if all of my colleagues have said no to their technologies, this is how patients sometimes land in my clinic. But yes, if they're not a candidate for surgery due to portal hypertension, if they're not a candidate for Y90 due to lung shunting, if they've already had a TACE, we need to try something else. So I think starting a person like this on systemic therapy, either with, depending on their degree of portal hypertension and, if presence of varices or not, if those are controlled, considering atezo-bev, and if not, considering the STRIDE regimen.
The other option just to think about, and again, if you do the TACE, restage them. You can also consider external beam radiation. That's something that we really haven't discussed. It's localized to that one side. It's not diffuse. If our radiation oncology colleagues can feel like they can conform it reasonably well without getting a lot of non-target dose, that's another option you can consider.
We ended up going with STRIDE, and this guy had a phenomenal response to STRIDE. However, he did start having an area grow, now 14 millimeters, and that huge tumor is now this small little cavity. And so this is definitely new compared to prior scans. And so do we consider switching to a different immunotherapy, or what are your thoughts?
You could switch to a different treatment, just a systemic therapy to second line for someone that is progressing. That would be within sort of the tenets of oncology. I think putting our common sense caps on, though, looking at this, it's very small. is this targetable now by locoregional therapy, and thinking outside the box and doing a laser focused therapy on that may make more sense than treating their whole body with a new regimen that might be more toxic.
And we've seen this a lot now, especially since a lot of patients with advanced tumors, large tumors, infiltrative tumors, got immunotherapy, had an awesome response, and then, 1 year, 2 years later, they have this little nodular recurrence that looks just like this. And we've been anecdotally very successful in getting them back to a complete response, right? So, and they've been able to stay on their systemic therapy, whether it's stride or atezobev and so on. The one thing is, in terms of adding a locoregional therapy approach here, it's not just that 13.5 millimeter nodule. Every single time we do a mapping angiogram, it's going to be more than that. So to target that with, let's say, an ablation is going to be inadequate. You're going to miss. You see that small nodule, but there's probably 3 or 4 others tucked in there as well. So every time we do a mapping angiogram, we'll see 3 to 4 times as much tumor. But it's, as long as it's all localized, it's very targetable, and it tends to be very straightforward as well. And so we've done that and kept them on their the same regimen, just as you said. But it doesn't make sense to completely switch, and you're burning a bridge that you may not need to burn that bridge because you want to get them 5 years, 7 years, whatever. And we've gotten durability from doing that.
So that's the
completely non-science based, of course.
That's the approach we took. And you can see on the left is the SPECT-CT, taking your advice and treating the whole region, knowing that there's more disease that we can see there. And now we're back to a complete response, no evidence of disease. And you can see the expected kind of T1 hyperintensity from the radiation effect. So now we're in a situation where, did we successfully downstage? Can we think about transplant? Does the immunotherapy give either of you guys pause with transplant?
What I'm gathering is that the total sort of presumed tumor diameter with the, issues in getting that precisely measured that you raised looks to be that it would be within a downstage criteria that we could consider transplantation for this patient. As to the immunotherapy, yes, this does become an issue. I think most programs are looking to discontinue that for 3 months or so ahead of going into transplant to avoid problems with rejection.
Yeah, I think Adam and I have a lot of experience with this. Fortunately or unfortunately, we were early dipping our toe in the water, the post-immunotherapy transplant, and found that if you have an insufficient washout period, then your risk of having very dramatic hepatotoxicity, that looks like severe refractory rejection is super high. And I think we were the center that came up with 3 months. Out of experience, that 6 weeks was inadequate for us, and 3 months seemed to work from having gone through it. So yeah, we would definitely consider transplant, but again, they have to have that washout period to ensure that, or to lower your risk. I think we still don't completely understand the process that's involved, and Adam, being much smarter than me, could probably explain the immunology behind the immunotherapy and how it really kind of changes your immune system dramatically, perhaps permanently, and again, in ways that we don't fully understand. So I think we have to be thoughtful and careful, but I do think immunotherapy can be used for downstaging.
Yeah. And I would just say, like, from a pharmacology perspective, just remember, these aren't oral medicines metabolized by the liver and the kidneys that wash out in a few days after stopping treatment, as you mentioned, Gabe. These are monoclonal antibodies that last in the system for weeks and probably do have some amount of, long-lasting remodulation of the immune system that we don't fully understand, but we need to be very mindful of. And the other point that I just would throw out there as we're thinking about transplant versus not is, for patients that are complete responders with immunotherapy or multimodality therapy, we know that the tails of these curves are quite long now. Stride data now out to 5 years showing overall survivors of 20%. Do patients need transplant? And I think for someone like this, the case is a bit clearer. This person, their portal hypertension actually is quite bad. They're requiring recurrent banding for their varices. Their platelets are hanging out about 50. I think, I'd be curious on Heather's input on what's their risk of death from cirrhosis alone and portal hypertension alone.
So actually, if you look at all the things that we look at to help inform prognosis, portal hypertension is the biggest predictor of mortality still. And so I would definitely encourage, if assuming that they are transplantable from, all the other angles, that be pursued for this person, if that's what they want.
It's interesting. I think Adam and I have had some cases as well, not transplant, but resection after long durations of stable immunotherapy with mixed results. I mean, sometimes you stop the immunotherapy and all of a sudden it's everywhere again, right? So I think we're still figuring this out. It's such novel therapy, and new drugs keep coming up, new monoclonal antibodies keep coming up. So I think it's an exciting time, but also one to be approached with some caution.